Thank you, Tom, and I want to begin by thanking the leadership of SAGES and the program committee for the pleasure to present to you this afternoon. As noted, the topic of my presentation is the future of healthcare strategy, policy, and growth, a daunting topic to say the least that could literally take us weeks to discuss in detail, but I'm going to try to distill in about 15 to 20 minutes or so. I'm a general surgeon. I practiced for about 25 years and was a member of the faculty in the Department of Surgery at Northwestern in Chicago. About 4.5 years ago or so, I joined a healthcare strategy consulting firm, SG2, based in Chicago, that itself was acquired about 2 to 3 years ago by the Vizient Corporation, a healthcare company based in Dallas, Texas, that has a wide variety of activities, including group purchasing, pharmacy activity, but in the consulting realm does strategy, operations, operational effectiveness, data analytics, quality improvement, and so forth. And really over the last number of years, I've had the chance in my role with Vizient and SG2 to interact with a variety of clients around the country, big, small, urban, rural, academics, non-academics, as it relates to their strategy, to their operations, to their enterprise, if you will. And those conversations and interactions really inform the information I'm going to share, the opinions that I'm going to express this afternoon. What I hope to do, is to highlight a handful of trends or items in healthcare that I hear our clients, strategists, administrators, C-suiters, as well as physicians speak about, those that really rise to the top amongst a wide host of items to discuss. I want to then discuss the interactions of strategy, policy, how that leads to growth, what I see changing amongst the planning process, if you will, of our leaders in healthcare organizations and hospitals. And then what I'm going to try to do near the end is bring that back to the individual surgeon. What does that mean for my practice? How should I respond? How should I act and react amongst this tremendously overwhelming at times healthcare environment that we find ourselves in? So with that, let me highlight a handful of topics that I hear most commonly, that we get questions most commonly from our client members. As you can see, the shift to outpatient care, consumerism, value-based care, and finally, consolidation. I'm going to speak briefly about the first three, but really dig in a little bit more in terms of consolidation, the merger and acquisition activity that's currently occurring and has occurred, because I think that actually has the potential to affect us most in terms of how we practice currently and in the future. First, outpatient care. This shift has been going on for a while, and it only will continue for the foreseeable future. What you see in the left-hand panel is our forecast of inpatient activity, the entire U.S. market over the next 10 years. The orange line is our actual forecast, so flat or slightly declining on the inpatient side. The gray dash line that you see would be growth if we simply used the population to drive that forecast. But as you know, there are lots of other things causing, despite increasing population, care to shift to outpatient. This organization has been at the forefront, certainly, of one of the biggest transformations, the shift to minimally invasive surgery, and how that has affected both length of stay as well as literally the status of the patient, inpatient versus outpatient. But there are a host of other clinical as well as payer incentives that have driven this shift. Now, some of you work at hospitals, particularly academic centers, tertiary quaternary centers, where you're busting at the seams, where occupancy is very high, where beds and buildings are being built or opened to accommodate the demand. That's true. But when you look at the whole country, it's really flat or slightly declining. So what's happening is that critical access hospitals, smaller hospitals, 100-bed, 150-bed hospitals are feeling significant pressure, often are changing their mission, if you will, to be more of an ambulatory site. And indeed, when you look at the transfer volumes to academic centers, it typically ranges about 15 to 18% of all admissions at those centers. I know of one center where it exceeds 30%. The typical community hospital, on the other hand, will have transfer volumes of 4 to 5%. So this shift of patients to certain places is causing significant inpatient activity, but overall we're flat. On the other hand, on the outpatient side, the bull run continues, if you will, both in terms of our improvements in care that shift, but also as the population ages. Tom showed this just a moment ago. We're having more patients in the system with more chronic illnesses and more surgical demand. So this shift from inpatient to outpatient is key. Strategists, hospital administrators, I find all too often oversimplify this. They look at this type of graph and they think that, well, everything is moving that way. And where we have to help them and be part of the conversation is to indicate, no, it's nuanced, it's complex. It varies by specialty. It sometimes varies by procedure. It can vary by individual surgeon. So be very careful in your planning how you think about this shift from inpatient to outpatient, because it will be different in different places. For total knee replacement in the state of Colorado, currently about 40% are done as outpatient. In many other states, particularly along the eastern seaboard, it's actually less than 5%. So there's geographic variation here as well. But I think we have a place at the table to inform these folks about what this shift means, how it works, what incents us to do so or not as they develop their planning. Secondly, value-based care. This means a lot of different things to a lot of different people. I would say, broadly speaking, that the excitement and rage of accountable care organizations, or ACOs, 5 to 10 years ago, quite bluntly, the shine is off the apple. They still exist. They're still around. They probably still will continue to be around for a while, but I think the momentum is not there as it was a number of years ago. On the other hand, when it comes to bundled payments or other alternative payment models, I think there's a lot of traction and a lot of momentum. I know one of our next speakers is going to talk about bundled payments, and it behooves us to pay careful attention and to get educated in this particular payment model as surgeons. Why? Because bundled payments lend themselves very nicely to discrete episodes of care. Surgery is exactly that. The decision for surgery can be measured when a patient reaches their full recovery or the most they're going to recover. That can be measured. The stakeholders at the table who participates in the surgical episode can be identified. One could argue that transplantation surgery is the original bundled payment, now going on 25, 30 years or more. So I think there is a lot of momentum in bundles, and I think it behooves us to understand this area well, as it may be an opportunity for us. And perhaps more broadly, the competencies necessary to do bundles and to do them successfully are competencies that I think, no matter what kind of environment you're in, fee-based or otherwise, are worth considering and having. And again, as Dr. Sachs, who's the retiring CMO at Advocate Aurora Health, put it, we're in a fee-based environment, but we're also in a value-based environment. We want to be good at both, to have a diversified portfolio depending on what opportunities may come before us. Consumerism. This is an area that gets a lot of attention, and that's why I listed it. But quite honestly, in my opinion, there's really a lot more talk than there is action. This is a favorite topic of people like myself who speak about healthcare broadly, and it allows one to check the obligatory Amazon box that is our new competitor, if you will. I don't mean to minimize any of this. It's real. It's there. But in terms of what I find healthcare organizations, hospitals, and the like really doing, again, more talk than action, quite frankly, with perhaps the one exception of access. I think access really does stand out as a differentiator, and I see more motivation, if you will, and more activity from organizations to address this issue. How easy is it to get an appointment? How long before I can get the appointment? And on the day of the appointment, what is the experience that I have? I think it really behooves us as we think about the quality of care that we provide to consider the access for our patients and have that on our dashboard along with all the other metrics that are very traditional for us. Now, I want to shift gears for a moment and talk about consolidation more broadly, merger and acquisition, or M&A activity as it's affectionately called. This has been around for a while, of course. It continues. It is likely to be part of our lives and our ecosystem, if you will, for some time to come. The value of deals continues to rise. In fact, most recently, Common Spirit, which was the merger of the Dignity and CHI systems, as you can see, almost 140 hospitals, 25,000 physicians, 28 billion or so in net revenue. A huge merger of hospital systems together, and they're not alone in this regard. These so-called horizontal mergers have been around. We think they're likely to continue. But in addition, we're starting to see vertical mergers. And again, this is relatively recent, but I think there is likely to be a lot of activity in this area. I've given here about one example. There are certainly others, CVS and Aetna. But here you have different healthcare organizations, or at least have a different portion of the space. The insurer, United, getting together with providers, Optum Care, and I should have put DaVita up here as well as pharmacy and pharmacy benefit management, to develop a vertical, hence vertical, not like organizations, but ones that complement one another, to develop a new system. And then even more recently is private equity. I think this is an area to watch very carefully. In 2018, better than 700 private equity deals in healthcare, combined value more than $100 billion. It's said, and it's not clearly known because they are private equity, they're not public companies, that public equity firms in the United States are sitting on a war chest of somewhere north of $650 billion currently and looking for places to invest. One of my friends works in a private equity firm, and he put it to me this way. He said, Jay, these firms have a lot of dollars. Healthcare is 18 to 20% of U.S. GDP, and from their standpoint, relatively recession-proof. Why wouldn't you invest in healthcare to have a diversified portfolio if you're an investor? So I think we'll see even greater acceleration, more money coming into the system to acquire, to merge, to reconfigure, and the like from various entities. And this is going to be an important part for all of us to be aware of. We're probably part of large systems, many of you right now. Those who aren't are likely to become part of a large system before too long. Now, here's the rub. By developing bigness, presumably there are economies of scale. And certainly that has been seen when organizations, 10, 20, 100 hospitals, whatever, merge their HR departments or perhaps their supply chain. But the reality is now there's enough of a track record that when it comes to the providers, when it comes to the patients, the actual delivery of healthcare, the promise has really not been fulfilled. There's really very sparse evidence that there's been significant improvements, for the most part, in the quality of care that's provided. And for the most part, certainly the cost of care typically goes up if it changes at all. Within Vizient is the University Health Consortium, UHC, which I'm sure many of you are familiar with, particularly the data that's driven from UHC. Our colleagues in the Research Institute at UHC did a year-long study of what happens with care when systems develop, clinically integrated systems and the like, versus systems or hospitals that are not part of a system. And I'm just giving you a glimpse here of the utilization of care as it relates to two entities, joint replacement patients discharged to skilled nursing facilities, or the percent of ED visits for back pain. The point is not to indicate a best practice or what should or should not happen. What I think the interesting part of this slide is that the orange bars, which are system hospitals, the gray bars, non-system hospitals, both exhibit significant variability within care across geographic regions which are located along the x-axis. In both of these areas, this group did a number of studies related to not only these, but various service lines with activities across service lines, and similarly found these results. There's significant variation that resides within the system, and systemness itself doesn't really create the dynamic, for the most part, that we minimize variation, that we manage our costs, that we really function as a group, so to speak. That's been very difficult to accomplish. Interestingly, just as a footnote, they also looked at systems that have been in place for 10 years or more to see if maybe there's a learning curve here. Found the exact same thing. So consequently, in this survey that we did of C-suiters, we found that reducing clinical variation was the #1 priority as C-suiters looked at their systems and what they hoped to accomplish or were interested in accomplishing. And I'm going to dig into that in just a little bit more in a moment. And also a migration towards a value-based care model. Can we succeed in a value-based environment? We may be in a fee-for-service environment, but what would it take for us to be able to succeed in both environments, not knowing the pace of change? Now, how's this going to affect us as a surgeon, as a practicing surgeon? What's going on here? I'm going to come back to this in just a moment, but for a moment I want to pivot to strategy. Strategy at its essence is competition. Michael Porter, the Harvard Business School professor, I think is really the guru of American corporate strategy, likes to say that developing and achieving a successful strategy is about obtaining, quote, a sustainable competitive advantage. A sustainable competitive advantage. What can we do that is different from our competitors, or similar activities that we do differently that distinguishes us? Now, I'm not going to argue with him at all. However, I would say in healthcare, it's a little more complex, because doing even the same activities, but better, more effectively, more efficiently, more reliably, more equitably, is also extraordinarily challenging when we talk about patient care. So I think, in fact, both strategy as well as execution are critical to a successful organization. And as these mergers have taken place, strategists and administrators are paying attention, frankly, to both. So when you think that the strategic plan at your hospital or healthcare organization seems to be changing every year, in fact, it is changing every year. The healthcare landscape is so dynamic, the environment we're in is so complex that there is a need to constantly reassess where we're at. These are some of the trends, and we've touched upon a few of them, that lead to these changes of planning and strategy on a regular basis. But again, I want to highlight two. The top one, the M&A activity, where now we have systems with multiple hospitals, and at the same time, the last one, the new data. We heard from Dr. Woodson this morning, I think very interesting, about the digitization of healthcare is the phrase he used. And what I'm saying is not so much from the patient standpoint, but from the system standpoint. They now have large numbers of hospitals where they can gather significant mountains of data, new data, diverse data. Quite honestly, they don't always know what to do with it. A COO that I worked with recently put it well, Jay, we're data rich and information poor. And yet we see some things that we don't understand. And that's where I think there's a significant need for we as physicians to be part of the conversation, to understand and help them understand what the relevant issues really are. We come back to this equation quite often. Value is quality over costs in terms of the business school sense. sense. And in healthcare, quality can be outcomes, processes, efficiency, effectiveness, the patient experience, satisfaction, access, and so forth. We can define it any number of ways, but now, of course, cost is very much part of that equation and one that we need to pay attention to, again, as Tom alluded to in his introductory remarks. Well, where is this leading us? Well, with this new and diverse types of data, this is the type of dashboard that our colleagues, our non-clinical colleagues on the hospital side or the organizational side now have at their fingertips. Let me walk you through this very briefly. Here, this is actual data from one of our clients looking at total hip replacement MSDRG 470. We have various providers. We have a hospital all rolled up together, Hospital A, and we have AMCs. The data is risk adjusted. Regression modeling has occurred for these patients, so we understand who's sicker, who's not, so forth and so on, and can use that data to develop an index, observed to expected ratio, for length of stay, for mortality, for costs itself. Now, it's not so much the numbers here that I want you to focus on. It's the idea that someone will look at this information and say, what's the deal? This is the same place. These are surgeons doing the same operation. We now can understand outcomes, perhaps. And if we see similar outcomes, why does the length of stay vary? Why do we vary compared to our benchmark competitors? Or why does one surgeon cost this much and another surgeon doing the same operation cost that much? These are the kinds of bits of conversation and queries that we receive that I hear about on a regular and frequent basis. And I think, again, it's a combination of a bigger system combined with new and diverse data that is now surfacing up. These are not necessarily punitive conversations. I've never heard somebody say, we got to get rid of that guy. They're awful. Rather, it's what's the source of the variation. So as Tom mentioned, utilization is actually flat or slightly declining. That's true, but there's still significant variation when we go away from the average. Quite often, in relatively straightforward operations, lap chole, sleeve gastrectomy, et cetera, you'll almost always see this type of variation within an institution and between institutions that is not clearly explicable. So I think this is going to be part of the conversation we'll be having and can have a very valuable contribution to those conversations to say to our colleagues, look, yeah, the data is important. Here's what's relevant. Here's what we need to know. Here's what can drive action. I practiced for 25 years. I never, to this day, never saw the cost of any operation that I did. I'm actually embarrassed to say that. I should have asked. I never did. Never dawned on me to ask. Nobody ever showed it to me. I'm not sure they had it. They have it now. Let me assure you. But the point is, it should not be a point of contention. This should not be adversarial. Quite often, if we just see the data, we're smart enough to figure out, you know what, I don't really need to use that. I can use this and still have the same quality. I'm sure of it. That's been shown time and time again across a variety of surgical specialties in particular, and I think we need to be prepared to be part of that conversation. This just is sort of, again, going to another level of detail. At this particular hospital, they put the consult in for PT a day later compared to their competitors, and you see the green line across the top, their length of stay is a little bit higher. Are other things contributing to that? Of course. But here's a relatively simple thing that we can do to potentially affect length of stay. We should prepare ourselves for these kinds of conversations and ideally should lead these kinds of conversations in terms of trying to, again, maximize the value of what we do. So we've lived in a volume-driven world. Some say we're going to a value-driven world. I'd push back on that. Volume is always going to be important. I've yet to hear anybody who says it's really not, at least honestly. But we also need to succeed in a value-driven world. How can we maximize the value of what we do? And in surgery, certainly quality, whatever that may mean to you, however you define it. But can we measure? I think we can. I think we can develop actionable insights, and I think we need to be part of that conversation with all the other items that are listed up here as well. So as we think about a growth strategy, as we think about looking forward to the future, hard to know what the future is going to bring. Yogi Berra said it the best. And I think it's fun to think about and speculate of the future, but the reality is it's just really hard to know. That doesn't mean that we should not think about it or consider it, but it means that we have to take the plans we have today with a grain of salt, as President Eisenhower put it, but consider how we plan, the data that we have, the mission we've described, how we define value, how we define quality, a shared understanding, presumably, with our hospital colleagues, and that we have an ongoing process that we become, to use the cliche, a learning organization where we can be proactive if possible, but quickly reactive and thoughtfully reactive when necessary. Finally, I want to end on this note, perhaps not necessarily inspirational, but at least practical. If healthcare, this overwhelming system that we live in, is the metaphorical bear, then we don't necessarily have to be faster than the bear. We just have to be faster than the other guy. So most patients don't travel that far for their care. We've actually studied this very carefully. In populations where density is 500 per square mile or greater, patients travel about 3.5 miles, 50%, 90% travel no more than 10 miles. So yes, we want to look at the big institutions, we want to look at the benchmarks, we want to look at what's happening around the country, but please pay very careful attention to what's happening in your own backyard. Thank you for your attention.